Greenberg. All right, good afternoon. Today is May the 12th, and it is 1:01 p.m. As a quorum of the committee is in attendance via our video conference, I'd like to call the meeting of the Central Health Strategic Planning Committee to order. Our first item of business is public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 11:30 a.m. today. Anais, is there anyone listed to make comments?
Hi, good afternoon. We have one person listed to make comments today. They are a staff member. So David, do I need to read the guidelines?
No, I think we'll be fine with just one commenter.
Okay, perfect. So our speaker today is Ppe Davila, Director of Communications and Community Engagement with Central Health.
Thank you. Thank you, Chair, and thank you, Anais. Hi, everyone. I just have a few things to say. Before my official start day at Central Health almost 4 years ago, Anais Cruz reached out to me directly, asking me to meet for coffee. This definitely set the tone for our working relationship at Central Health. She's an incredibly organized person, and she's shown great initiative over the past 4 years that I've worked with her at Central Health. And so after 5 years of service at Central Health, Anais has accepted a position with CDNP, a community engagement firm based in Austin, and her last day at Central Health is next Friday. Her incredible attention to detail and superb organizational skills have always come in handy to make sure our department runs as efficient as possible. I think I can speak on behalf of our team when I say we will sorely miss Anais's organizational and planning skills tremendously. And of course, on a more personal note, we will also miss her witty humor. We of course wish Anais the best of luck in her new endeavors, and I'm sure we will see her again soon. Thanks, Anais, for everything you've done at Central Health.
Thank you, Yvonne. And Anais, you will be greatly missed, but it is just such a great thing to see our staff move up the ladder and be promoted and just have excellence and show excellence. And we wish you all the best, but don't forget about us. You know, come back and say hi, see how we're doing. And, but good luck. We really appreciate all you've done for us.
Thank you so much. And thanks, Yvonne. That concludes citizens communication for today.
Thank you, Anais. Okay. I would now like to lay out agenda item number 1, review and approve the minutes of the April 14th, 2021 meeting of the Strategic Planning Committee. Do I have a motion? I have a motion by Manager Valadez. Do I have a second? I have a second by Chair Greenberg. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Okay, agenda item number 2, receive and discuss an update on fiscal year 2021 strategic priorities and fiscal year 2022 proposed strategic and operational priorities. Before I start the presentations, I'd like to request I'd like to make a request of our committee members and board members who are in attendance. This agenda item is a long one. It makes the meeting look short, but the item is going to take a while to go through. And so based on that, instead of waiting until the end of the presentation for questions, I will open the floor for questions and comments at multiple points during the presentation. So still ask that you write your questions down and wait until that point, but I'm not going to wait until the very end of the presentation because your questions then won't sort of make sense because they won't be reflective of the topics that we're talking about. Manager Valadez?
Dr. Bell, I've written some brief comments for each of the sections. Can I go ahead and send them to you right now? I mean, excuse the language or excuse the the format, do you mind if I just send them to you? Because I can't hold them open at the same time that I'm watching the board member, watching the presentations. So I'd like for you to have them at least so that they can be made part of the record, and I can hopefully get some responses.
Okay. Yes, you can send them to me.
I'll do that right now.
Yeah, you've got my email address and everything, right?
Thank you. Thank you.
Okay, great. Okay, I do want to remind the members that our comments, however passionate, should be respectful of the staff who are providing us the information. It's always appropriate for me or any other member to express our passion for a topic or our concerns with activities either being performed or those activities that are not being performed. But I ask that each member do 3 things when providing comments or questions of staff. The first is to be respectful of the staff providing the information at all times. And let me say that I've used this technique before, but it doesn't make it right. An upfront apology prior to making a comment that demeans or berates staff or any member of the public is still not appropriate. Number 2, please make your comments and questions as concise and as clear as possible. If you can't formulate a request or a question in that manner, please work with the chair, myself, or other board members or staff offline to develop your request so we can make sure you get the appropriate responses. And number 3, please keep your comments and questions on topic. If you have comments and questions that isn't on topic, either discuss that issue, discuss the issue you're trying to outline, either with the chair, myself, or staff after the meeting, so we can work together to see how we can address it. Our staff, our central health staff, is one of the most valuable assets that we have. And we want them to know that we are in a collaborative partnership with them to help the people that we serve. They do fantastic work. And I personally would like to thank you every day for what you do. And I'm sure that all of the other board members feel the same. At this time, I'd like to recognize Mike Kiesland to add some comments.
Yes, thank you, Mr. Chair, for your comments, and members for your time and attention today. I'd like to focus on one of our 4 central health values, which is collaboration. The staff, before I turn it over to Monica and the very talented team that you'll hear from today, as with all staff, even that are not presenting today, this is our life work, and it is our privilege to present to you, and it is our privilege to serve. We also know that each of us has different experiences, and many of us have not lived an experience. We don't know what it's like to wake up Black in the United States of America. We don't know what it's like to be poor. We don't know what it's like to hold down 3 jobs and care for multiple generations within the same household. But yet we seek and strive for an understanding. And what we don't have in our own experiences, again, as part of our life work and collaboration, we work with those that do. And so with that, we know that we are stronger when we stick together and being aligned with the board and with the community that we serve. And that is a form of collaboration and one way that we can serve in a very impactful and meaningful way. So I make those remarks on behalf of the staff, but also to reaffirm our commitment towards our value of collaboration and what it means to seek understanding of, and also to appreciate that those that may have not lived an experience also have a tremendous amount to contribute as we work for the population, again, that we're so privileged to serve. Thank you for allowing me to make those comments.
Thank you very much, Mr. Giesman. I appreciate that. And I will now recognize Monica Crowley to lay out this item, and she will introduce other speakers for their specific topics. Monica?
Thank you so much, Dr. Bell. This item includes both an update on where we are to date and highlights of the work that has been completed towards achieving the fiscal year 2021 budget resolution strategic and operational priorities. Mike Gieslin is going to update you on our planning and work cycles for Central Health and how we arrived at this process. I'm going to remind you of what the strategic objectives under our current strategic plan and the annual fiscal year 2021 priorities are. And then I feel so honored to be able to bring staff members Kit Abdi-Spels, Veronica Buitron Camacho, Ted Burton, Megan Cermak, John Clark, Sarita Clark-Leach, Cynthia Gallegos, Rachel Hardergree, and Jonathan Morgan to present to you on work that we have done towards the fiscal year 2021 priorities. We're not going to present on every priority because some of them you received presentations on during the last board meeting. And then we are going to do a very high level presentation of the initial proposed fiscal year 2022 strategic budget resolution priorities and operational excellence priorities. So Mike, if you'd like to kick it off.
Yes, thank you. So if we can advance to the next slide. So members, as a board, you receive knowledge through different channels, and what these tiles represent are a few of the channels, mostly more formal, but some informal. That's our culture update. So for example, we've heard about the hub disparity work and what we're doing to improve upon the inclusivity and diversity of our workforce. The other is dashboards. Literally, there's a dashboard on our website that talks about or speaks to those whom we serve. But also you receive other dashboard updates throughout the year. There's the annual report that was recently released. There's the biennial demographic report that shows how we're doing within the communities that we serve, email updates. But the one that we're going to focus on today is our strategic objective updates. And that's the tile that's there in the middle of the image on the right side of the document. Next slide, please. Okay, if I could orient your attention to 12 o'clock on this diagram here. We're between the cycle where we're starting the budget process, and this is a board cycle, if you will, that start, we're working and we're reporting on items, but we're also seeking direction. And that's going to lead to the May-August timeframe, and these timeframes overlap, obviously, which is where we start to establish and this is a board prerogative, what our strategic objectives and philosophies will be along with the budget, so that way we can bring those in for alignment in September under the budget resolution. So really where we are, again, is we're at the top of this illustration here at the 12 o'clock point, and it's really about realigning. It's about checking where we are, where we need to be going in service of the population and that we serve, and what those realignments might look like. I should also point out that there is a staff work cycle that is aligned with this and comports with what the board is doing. Again, this is about alignment, and collaboration is one of our strengths. Next slide, please. So this is a chronology that shows where we've come from and where we are headed into 2024. And it spans the time frame from 2018 to 2024. And that's significant because the board established 6 years board defined objectives, which Monica will cover in the next slide. But I'm going to start out real quickly and just walk through this. And again, this is just to reacclimate both current as well as more recent board members, more recent board members that have joined the board. So in 2018, we concluded a 5-year performance review, also known as the Germain Report. And this was pursuant to board directive, but also to a Travis County Commissioner's Court, that we have a performance review. The strategic objectives were, they were worked on in 2017, but they were memorialized and established for 2018. That takes us all the way through 2024. The other significant development is that we started using the budget resolution, the annual budget resolution, as a foundational document. And we look at this as a way to memorialize both the strategic directions established by the board, but also as a mechanism that adopts the actual budget that funds our strategic work and our day-to-day work. It is also an important compact with the community. Anybody can look at it. It's on our website. We provide paper copies to anybody that would ask, or email it, and people can see. yes, these are what the strategic objectives are as established by the governing authority for the district, which is the board, and the budget that goes along with those strategic objectives. Now that takes us to 2019 through 2021, which again, coming back to the strategic objectives and the budget adopted by the board, we work to align and meet certain milestones, and then we report on those milestones. I'm going to advance over to 2022 and 2023. So this time frame is going to be a critical time in our history. As a healthcare district, we are maturing, we are growing, we have an ever increasing complexity in our operating environment. But those are all challenges that we're up to, but we know what those challenges are, or we have mechanisms in place to determine what those challenges are and make sure that we're able to rise to meet them. So what you'll see in the next couple of years, and this will be talked about extensively in this presentation, is an equity focus on our healthcare strategy and how we need to realign to really drill down into what is equitable healthcare and what are those gaps that need to be closed. And this is just taking our work that has been done over the years and putting building blocks in place and measuring outcome-based healthcare. It just takes it all to the next level. This also sets us up for the next 5-year performance review. Now the procurement for this, if we stay on target and on schedule, will need to be sometime in late 2022, and then the work commenced and concluded in 2023. And again, this will restart the process for realignment as we move forward into 2024 for new directions and a refined strategy, but also having measurable health outcomes. Similar to what you've already seen in the demographic report, where we report on disease prevalence and outcomes amongst the populations and the communities that we serve, but again, much more refined. So I'll turn it back over to Monica at this point. Thank you.
Next slide, please. So just as a reminder, and for the new managers, the strategic plan board-defined objectives for 2019 to 2024 that we are currently operating under and that we will continue to operate under in the next year include to develop and execute healthcare delivery strategy based on people in place, to implement patient-focused and to implement a patient-focused and coordinated healthcare system, and to implement a sustainable financial model for healthcare delivery and system strategies through fiscal year 2024. And these objectives have been the basis for that we build our annual budget priorities and our annual work on each year. And so next slide, please. You can see how the adopted strategic priorities for fiscal year 2021 that we've been operating under move us towards achieving the board-defined objectives. And the board adopted strategic priorities for fiscal year 2021 include in support of Objective 1, our healthcare delivery based upon people in place, Eastern Travis County site expansions, building our HUD program and procurement to become more equitable, to improve central health recruitment strategies, to implement an equity and inclusion task force, and to support our partners in the community in the pandemic response. Under Objective 2, implementing a patient-focused and coordinated healthcare system. It included the beginning of the systems-based planning and health equity work, specialty care access improvements, which we know have been an ongoing opportunity for Central Health and priority for Central Health, to build a Central Health customer care center, which is a call center that is built inside Central Health, and additional improvements to our eligibility and enrollment process, to help community care implement its new electronic health record, Epic, to expand telemedicine and virtual care options, and to expand case management and outreach. Also, in working towards our sustainable financial model for healthcare delivery, this has included working on our hospital payment model and continuing the Brackenridge downtown campus development in support of our long-term mission and to provide funding so that we can continue to provide access to healthcare as our population grows and the complexity of care that we need to provide also grows. And so at this point, Dr. Bell, we're about to transition into the report outs on many of these priorities. So I don't know if you'd like to open it up for questions now.
I would, and I would like to first have a couple of questions myself. Manager Valadez, I did receive your comments, so you're going to hear me reflect some of your comments. And if I don't reflect them correctly, please tell me, all right? Monica, as we looked at the first couple of slides, the board knowledge and the annual cycle and the strategic timeline, there wasn't much mention of how the public sort of integrates into this system. And so in essence, could you explain to us, like, I know board knowledge means that you are educating the board on certain issues and strategic policies and plans, but that does involve a public interaction, and we didn't sort of see that. So could you explain how that works for us?
Absolutely, and I'm gonna go and I'll hand it off to Mike first, but I think at the very highest level, and of course Ted and Yvonne are here, and I think they present the plan on their community engagement plan around these priorities that are adopted every year. But I think at every layer, community engagement, patient surveys, that community focus has been part of everything that is included on those timelines and in those slides at a high level. But for more detail, I'm going to pass it to Mike, and then I think Ted and Yvonne can add a lot more detail.
Mike?
Yes, thank you. And we will get into this, I believe, on the second to last slide. I believe we'll address this matter, Dr. Bell, as well. But the key and operable phrase there is what Monica just said, which is the public input and how we connect with individuals is part of everything that we do. And it's not, so for example, with Eastern Travis County, we have advisory committees that we work with there in the communities where the sites will be located. And so that is going to continue. Now, to go back to the chronology of this, the 3 strategic objectives that were established back in late 17 and memorialized and activated in 2018, that was in part, large part, due to a lot of outreach and engagement to help build those objectives out. There were significant listening tours on the part of many staff, myself included, and also what I recall are some focus groups that took place at some of the health and wellness centers. And those are just a couple of examples. And then there were a lot of community conversations, which we continue to this day. But I think I can certainly address this in more detail after it's presented through these slides, and then we'll get to that second to last slide of what organizational excellence means.
Okay, thank you. And then one final comment, and then I'll open it up for other committee members to ask their questions or provide comments. In the slide that's directly in front of us right now, there's no mention of our sort of work for or our initiatives for our CHAP patients, which is Sendero. And so Sendero sort of fits within many of those objectives, if not a particular one. And is it included in there and we're just not seeing it, or how is it sort of represented?
I think that was, oh, go ahead, Mike.
No, please, Monica, go ahead.
I'm going to say, I think that was one that was an expansion last year into this year. It was adopted budget resolution, strategic priority to stand up the chat program. And instead of saying this, I'm going to hand it off to Stephanie because she has actually done a lot of the work. And this presentation is about letting the people who do the work do the talking. So
that was Kit Abney-Spelse's team and Sarita Clark-Leach's team and others. I don't have the brain power that they do. But what we did is we did have it as identified in the budget resolution, but now we've operationalized it. It's become part of our regular work. And so we're not calling it out in this year's budget resolution in the same way we did in the previous resolution because we've embedded it into our operations.
Fantastic. Mike, did I see you have anything to add or no?
Yes, sir. Actually, Stephanie covered it perfectly. And so I'll just latch on to her words. The one thing that I would like to add is, we talk about the budget resolution as a foundational document, and that does two things. It sets forth the strategic objectives and priorities as established by the board, but also adopts the budget. The budget in and of itself is a policy document. It is an expression of policy. And so, for instance, if you see funding dedicated towards premium expansion for Sendero, for chat patients, then chat members, then that's an expression of the board's policy. So I wanted to point that out, that some things that may not fall under the three objectives certainly are given ultimate priority by the board just by virtue of adopting the budget. Thank you.
Thank you, Mike. Appreciate that. So now, any committee members have any questions about what we've covered so far? Any comments that they would like to make? Manager Valadez.
Well, Dr. Bell, what I was going to offer is, since I sent them to you and you did touch on some of what I covered, I'd like the other board members to speak, and then I'll finish it up if they have not covered what I wanted to include.
Okay.
I appreciate that. Thank you, sir.
Thank you. Okay. I don't see any questions from any other board members. So did you want to speak, Manager Valadez?
Yes, thank you very much. And thank you for raising the issue with respect to Sendero. They included by name because they're part of Central Health and they're part of our enterprise. And as Mike stated so eloquently earlier, if something, it is a budget, our budget is a resolution, is a policy document. And what I have major with is if it's not stated in the document, if it's not specifically there at in time, at his knowledge or assumptions based on other documents will not be considered and are lost. So I would, can you hear me?
You're breaking up, but we can hear you.
I appreciate that. So I'd like for that to be specifically included then. And the very first thing that I put on here was that we were missing that little hexagon or whatever it is that states that we needed to have required community participation throughout the process, including at the beginning. Because we are engaging upon the development of focus on patient of that system, then we need to make sure that the patient, and which I'm saying is not necessarily just a MAP patient or a MAP basic patient or a CHAP patient. I'm talking about our patients, according to our mission, are also the uninsured, which are the 200,000 people plus, I would assume at this point, that do not have and are not a part of our system, that may not have insurance or have Central Health resources at their, as part of their repertoire of healthcare services. And so I just want to make sure that they are understood to be our overarching targeted patient population. And then also with respect to the timeline, one of the things I wanted for us to be able to include, if at all possible, was public participation roundtables. I know that in our as we go throughout the year and we expand on the work that we are doing with respect to our strategic principles and our priorities, and then the development or the incorporation of those into our budget and then ultimately the budget document that we present to the Commissioners Court. I want to make sure that throughout the process, we don't have to be asking, is there going to be, or has there been public participation or community participation? And with, again, with respect to what that means, to me, it is appropriately demographic information and inclusion of their concerns and their thoughts from the very beginning, in the development stage, the tweaking stage of recommendations that come out, and also incorporation into the implementation stage of that. So I think that's it.
So far. Mike?
Okay, but we stopped where, Monica? Did we stop at?
We stopped right where the slide is now. And so the slide now did not include Sendero. We
to make sure we included Sendero. Thank you.
Thank you very much, Manager Valdez. We appreciate it. Mike, did you have something to add?
Yes, I just wanted to comment on Manager Valdez's last phrase there. You know, we agree, and that's why over the years, you know, we've had those engagement points, and whether it's community conversations, through surveys, through focus groups, through one-to-one direct outreach, through going to events on Saturdays and talking to people. I mean, it spans the spectrum of humanly possible outreach in a diverse community. And so I think that that's going to continue to be what we do. And I know it's been a few meetings back, but we can bring back that communications and outreach strategy back to this committee, Dr. Bell, when it's at the appropriate time. And I think that would be appropriate as we head into this budget season to have a refresh on that. And because there's some things that are being tweaked based on lessons learned and many of our community partners that we work with and advocates out in the community. Thank you.
Just a quick response.
Go ahead, very quick.
Very quickly. Mike, I was there at a time when Central Health did not engage in community inclusion and discussions and conversations the way that you have included that in your tenure. And as a result, I can remember and have that knowledge, as any of the other board members who have been on the board as long as I have or prior. No one at Central Health included the public in their development of conversational development of ideas, concerns. This is what I would like to see happen. This is where I am now. This is why I'm not satisfied. This is why I don't know what Central Health is and its resources are. We didn't have those conversations. And we did not have them, especially with respect to including the appropriate demographic statistical numbers that we needed to have their inclusion relevant to the development of recommendations. And so I respect the new culture at Central Health, even though there are some people who were here before. I respect it is your leadership and your team's leadership, executive leadership, that is incorporating a lot of what I have asked for in the past and what other board members have asked for with respect to demographic inclusion. But we still have a long ways to go, because we're still dealing with inequities, especially in light of this pandemic. Thank God, unfortunately, that at least is hot force and systems around the city, county, to address the vast inequities that have historically existed. They didn't just pop up. They have existed all this time. And so I thank you and I thank your team for doing everything that they can to make sure we overcome those inequities and eliminate those barriers. Thank you.
Thank you, Manager Valdez. Are there any other comments? And I would like to welcome to the meeting. I see you, Chair Greenberg, I'll get to you. I'd like to welcome to the meeting Manager Motwani and Manager Jones, who we haven't seen in a while. And we surely welcome him back. And I look forward to hearing about your adventures at the city. I'm sure that you have many stories to tell. Chair Greenberg.
Yes. Well, I second that. Welcome to the meeting, Manager Motwani, and welcome back, Manager Jones. We so appreciate having you back with our board. And I know that there have been some appointments at the city, one that took effect, I believe, Monday, that released you. So we're very happy about that. I just wanted to add my thank you to the staff for the excellent demographic work and other work that you have been doing. I really deeply appreciate the work that I have been seeing. Thank you so much.
It has been excellent. Thank you. Okay, Monica, I'm going to turn it back to you and we'll keep going.
Okay, the next slide, please. And I'm going to turn it back to Stephanie McDonald and Rachel Hardigree.
Thanks, Monica. This is just a trailer, a preview. The full episode will be coming to the board meeting at the end of May. And there has been a substantial amount of work, primarily in the Del Valley and Hornsby Bend Health and Wellness Centers. Kudos to Rachel Taranja, who's been managing the design team. You know, most of this has really been on her shoulders. I do want to let Rachel Hardigree give you an update today. But before I turn it over to Rachel, I want to acknowledge Rachel's contribution. I might give her a Best Supporting Project Manager award if I could. Rachel has really been critical in this process. She is connecting us to the data. She is making sure that we are connected to the healthcare delivery strategy, and has been part of the healthcare delivery team for a few years now. We really have benefited from her professionalism and her experience. I didn't know this until I started working with her, but she has a lot of experience in Pediatric Primary Care Association work and other healthcare delivery settings. Her project management skills are unparalleled. And I'm really sad to let you all know that her family is moving, and it is a career advancement for her family. So I'm very excited and I want to congratulate them, but I am very personally disappointed because I have so enjoyed working with Rachel. And I think these projects through their various iterations have really benefited from her expertise and skill. So with that, thank you, Rachel, and I'm going to turn it over to you for the update.
Okay.
Thank you, Rachel.
All right, thank you guys. Thank you, Stephanie. I appreciate those kind words. I really do. This work has meant so much to me, and it's really been a learning experience, I think, for all of us, but it's something I hold dear to my heart. So I'm really excited to provide my last update for you all. At this time, and as Stephanie mentioned, at the board meeting later in the month, we'll have more detailed information for you. So I'm going to try to roll through at a very high level where we are now. So this image that you see on this screen is essentially the preliminary project plan update that we provided back in January, which outlines the the clinical services that we anticipate for the Hornsby Bend and Del Valley Health and Wellness Centers. I wanted to update you all that the internal project team is continuing with its ongoing non-clinical service planning efforts to address prevention and wellness strategies to ensure alignment with the larger systems-based planning work that we'll be discussing in more detail as well throughout this meeting and many others. Additionally, the Central Health Communications and Outreach team has done tremendous work conducting one-on-one phone interviews, online surveys, in addition to those community advisory committee meetings and community conversations to gather input from the communities and to engage the communities to help inform these non-clinical service planning efforts that are underway. In terms of the physical structure for these facilities, a lot of work, as Stephanie mentioned, Rachel Taranja, big kudos for her. The schematic design and floor plan design concepts for both Hornsby Bend and Del Valley have been shared with our clinical operator and the community. We have civil engineering firms engaged for both sites, and we're in the midst of the design process, well on our way moving forward, and there will be much more information to share in detail for you at the end of the month. So that concludes really a very high level, just skim the top there. A lot of work going on, great stuff is coming, and we're very excited to move forward. And that concludes my presentation.
Thank you, Rachel, and good luck. We'll miss you.
Thank you.
Monica?
Our Next slide is going to be Megan Cermak talking about our pandemic response, and then following that, Ted Burton.
Great.
Thank you. Good afternoon, everyone. I'm going to be touching on our COVID response in this past fiscal year. I'm going to focus my time specifically on the efforts that we've undergone to fund COVID response operations and provide programmatic support to our safety net providers. And then I'm going to turn it over to Ted to talk about communications, engagement, and outreach, which was so critical during the COVID response. And when I talk about our funding and programmatic support, it was offered to all of our safety net providers. However, I really want to highlight our partnership with Community Care, because they stepped up in a way I believe was unprecedented for a safety net clinic system in a disaster. And I think really are one of the true unsung heroes of the COVID response in our community. Having said that, early on in the disaster, when we finally had access to PPE and testing supplies, Community Care had opened up its testing efforts, not only to their established patients, but to the community at large. And so Central Health wanted to support and expand that, those testing efforts. The first mass testing site that Community Care stood up was in alignment with the Hancock Clinic. We had identified that there was a gap of testing resources in the southeast quadrant of Travis County. And so we, and by we, I mean really Stephanie McDonald and her team, worked to procure a warehouse off Burleson Road that would serve as a testing hub in the southeast quadrant of Travis County, and having Community Care operate it. This testing hub not only served Community Care patients, but the community at large. The second thing that we did early on in the pandemic was we had to stand up some contact tracing efforts to support the testing hubs. APH did not have the capacity to meet the demand of contact tracing. And so we at Community Care, specifically Sarah Cook, working with the team at, we at Central Health, specifically Sarah Cook, working with the team at Community Care, Etta Kaglar, entered into a contract with Latino Healthcare Forum. And the community health workers at Latino Healthcare Forum really are the ones who stood up the contact tracing program. Early on, we learned that people were less interested in sharing their contacts and more interested in being connected to wraparound services, social supports, and an overall wellness check, which Latino Healthcare Forum did an amazing job at. When we entered into a lull and found less of a need for contact tracing or case investigation, we continued the contract with Latino Healthcare Forum to start enrolling people in MyChart, and that would serve as vaccine notification and vaccine registry. That kind of brings us into the lull between the first surge and the second surge. We as a community knew that that second surge was going to be much more devastating than the first surge. And luckily we did have a couple of months to prepare and plan for that second surge. There were two critical ways that Central Health stepped up in order to plan for and prepare for that second surge. The first was we launched a major PPE distribution campaign, and this was under the leadership of Elizabeth Marrero. We set out a goal to distribute 100,000 masks to the community, specifically people who lived in high-risk zip codes, before the second surge. Ultimately, what this campaign looked like was the distribution of 20,500 PPE kits. We met that goal of 100,000 masks. We were able to distribute 30,000 hand sanitizers along with educational material. We were under Elizabeth, of course. She met that goal very quickly. And so we asked APH to match our efforts, which they did. The second thing we did in preparation of the second surge was we knew that the second surge was going to time up with flu season. We knew that our local hospitals did not have the capacity to meet the COVID beds that were going to be needed in the second surge, much less have any capacity to treat flu patients. So we entered into a planning effort with APH and Community Care. For the fall of 2021, APH had procured 5,000 flu vaccines for the uninsured and underinsured in Travis County. Community Care procured 20,000 for its patient population. We increased capacity at Community Care by 50% by procuring 10,000 extra flu vaccines for Community Care. Last week was week 16 of flu surveillance, and I believe that we had 109 confirmed flu cases in Travis County, which I think is by far the lowest amount of flu that we've ever had on record since we've started flu surveillance in our county. And Manager Jones may correct me on that if I'm wrong. So those were the two critical things that we did in preparation of the second surge. That brings me into the timeline of when vaccines started trickling into our community. If you all recall, vaccines were trickling in allotments of a couple hundred, maybe 1,000 at a time. These were not a steady or stable supply. So 1 week, vaccine providers might get 1,000, next week they didn't get anything, and there didn't appear to be a whole lot of rhyme or reason to it. A couple of things that we did at Central Health to support our vaccine providers and specifically community care was, first thing was we transitioned that Burleson Road warehouse. We flipped it from a testing site to a vaccine site for established community care patients. Second, we helped stand up Rosewood Zaragoza as a vaccine hub for established community care patients. The third thing we did, which I really think is an untold story here in Travis County, was we as a community lobbied DSHS and said, give us a mass amount of vaccines and let us show you that we can distribute them as a mass vaccine hub. DSHS granted that request. They gave APH 10,000 vaccines, about a 1 week time frame to distribute those vaccines. They gave them about a 2 to 3 day lead time in order to stand up a mass vaccination site, and also with the understanding that there could be no vaccine waste. So all eyes were on this pilot that was stood up at Delco. One thing that I think a lot of people don't know is that Central Health staff and community care staff were critical to the success of that pilot at Delco. And this really laid the foundation for us having mass vaccination sites here in Travis County. We at Central Health and Community Care worked together to ensure that our safety net patient population was prioritized especially the first 3 days of that pilot. Stephanie McDonald worked really hard to make sure that our CHAP expansion patients specifically were included in those first 3 days. And staff was at Delco before the doors even opened. Number one, ensuring the success of the pilot, making sure that APH was going to meet its numbers. And number two, trying to smooth out operations as best we could, bringing the lessons learned from the Rosewood Zaragoza site. We also provided support at CODA. This was a huge initiative for our Human Resources Department. They had to launch an enterprise-wide, or I'm sorry, actually it was a Central Health and Sendero-wide employee volunteer program in order to ensure that we could support Rosewood, Zaragoza, and CODA on their daily COVID vaccine operations. I think that my bullet point fell off the slide here, but the last thing we did in FY21 and launching us into FY22 was to launch an equity enhancement payment program. And essentially what that is financially incentivizing our safety net providers who were distributing vaccines to make sure that their vaccine resources was going to people who lived in high-risk zip codes. And we worked with our data team to identify 20 zip codes that had high concentrations of poverty, where a large percentage of Blacks and Latinos lived, where there were high COVID transmission rates. About 80% of our MAP population lived in those 20 zip codes. And that program just launched at the end of FY21, and we look forward to bringing the board updates on that in FY22. With that, I'll turn it over to Ted to talk about communications, engagement, and outreach. Thank you.
Thank you.
Thank you, Megan. Hi, everybody. Ted Burton, Vice President of Communications. Thanks for letting us share some of the things that we've been doing the past 14 months regarding community engagement, outreach, and communications. As we reported to you in April, the COVID pandemic forced us to quickly pivot our engagement and outreach activities that had been traditionally in person to virtual, similar to transitioning in-person medical appointments to telehealth. As a result, we quickly sharpened our use of technology and found creative, new COVID-safe ways to deliver life-saving information. I'd like to also point out that while I get to present this information to you today, I am surrounded by a team of people who are much more talented than me, who are responsible for making all these things happen. And I will cover some of those in the next some of the things that we did in the past 14 months. But I'll start with engagement and outreach. Under the leadership of Yvonne Davila and Izela Guerra, all of our community meetings became virtual. Like the entire country, we moved to a world of Zoom, from meetings like these, our board meetings, to community conversations, advisory committee meetings, and partner meetings. The phrase or the catchphrase, "you're on mute," has become a line that we're all very, very familiar with. We have hosted bi-weekly partner calls. These are calls with partners to discuss coordinated outreach efforts so that we can learn from each other and make sure that we work more efficiently. Central Health has also joined weekly calls with APH Del Medical School, UT Austin Integral Care, and the hospital systems to talk about our coordinated communication efforts. We recently launched a town hall series in partnership with Black and Latino faith communities. We've hosted two. Our next one is this coming Tuesday. Community Care asked us to help them address disproportionately low vaccine rates and vaccine hesitancy among the African American population and the Latino community. Our partner Community Coalition for Health helped us connect with about 10 local African American churches, and we prepared and planned a series of town halls that will happen between now and June called COVID Vaccines in Our Community, Facts, Myths, and Overcoming Fear. Our effort mirrors a national initiative that's been funded by the Biden administration to address fear and misinformation regarding vaccines in communities of color. Latino Healthcare Forum is also helping us coordinate a Spanish language town hall for May 25th. Megan has already mentioned the drive-through PPE events, but we also transitioned events like our back to school events to drive-through events to keep our patients safe and our staff safe. We send out weekly emails to stakeholders. About 600 stakeholders are on that list. These are COVID updates, and we have a really good open rate for those emails, and perhaps many of you are on that email distribution list. We interact regularly with 93 Facebook groups. Many of those include members. Their members live in high-risk zip codes, so we send out information about COVID testing, vaccines, self-isolation, how to protect yourself and your family. We continue our partner outreach specifically for message amplification. So working with partners to create, test, and amplify our COVID messages in multiple languages. Our community health workers, 2 of which are now full-time members of our team, have made phone calls to 6,698 MAP members, many who speak Spanish only, and have actually connected to more than 4,100 MAP members. Talking to them early on about how and where to get tested, how to keep their family safe, and now have transitioned into information about vaccines, how and where to get vaccinated. Back last summer, or actually in May, we launched a business outreach initiative working with our consultants, Community Coalition for Health and Latino Healthcare Forum. We prepared toolkits that we could deliver to businesses, multifamily housing locations, and faith-based centers. To date, we have visited more than 1,100 businesses, faith-based organizations, and apartment complexes, and about 11 high-risk zip codes. And those toolkits include PPE, posters, fact sheets, that sort of thing. And then 980 of those organizations have signed on as partners in our COVID-19 efforts. And then last, on the engagement outreach side, again, working with our consultants who've been invaluable partners throughout this whole process, we have actually registered more than 3,300 people for vaccines. So primarily focused on communities of color and high-risk zip codes. We've actually enrolled them for vaccines, registered them vaccines, either through MyChart or getting them to go to CODA or other public vaccine locations. Now I'll quickly shift to our paid media and advertising efforts. Under the leadership of Mike McKinnon and Anastasia Mitchell, We have placed approximately $320,000 in media. This includes digital advertising, search engine marketing, radio spots, social media ads, and a direct mail campaign, which I believe has been very effective. We have sent 5 postcards to approximately 38,000 MAP households. So that's 190,000 cards altogether. And we are working on the 6th series. We recently incorporated a QR code on the last 2 rounds, and have found that has been an effective way to connect people to information. All told, our advertising efforts have resulted in more than 30 million impressions and more than 108,000 engagements, meaning through our advertising and media efforts, people have clicked through to a website, called a phone number, etc. We've been very active in the earned media and social media realm, and I'm sure most of you have seen some of that work. Our team, this kind of takes my breath away, but our team in-house has produced 75 videos in English and Spanish. We've written and distributed 45 press releases about central health and community care, resulting in more than 300 media mentions, and the paid media value equivalency is $11 million, meaning if we went out and purchased that same amount of media attention and engagement, it would cost $11 million. So that is a recap of some of our efforts, and we're happy to answer questions if you have any about what we've been doing in the communications and outreach world.
So Dr. Bell, would you like to open it up for questions now?
Yes, I would. And I see he just walked away from the camera, but I was going to welcome Dr. Pete. And anyway, he'll be back, I'm sure. Got a lot of things on his mind. One thing that I had a question on, either Megan or Ted, is did we learn anything for additional types of outreach to hard populations or populations that are hard to reach? We learned a lot from the pandemic. And so, but one thing that sort of has been not only in the news, but has been talked about a lot is outreach to particularly hard to reach populations. What did we learn anything based on this, of something that, you know, if we have another pandemic or an issue, I don't want any of those, believe me, but you know, it's possible. And so what would we do differently?
Do you want?
Either you or Megan, it doesn't matter.
I think one lesson learned for us is that the value of our partnerships, working with our affiliates, coordinating with Austin Public Health and others has been critical to make sure that we attempt to create and distribute unified messaging. I think that's been helpful. There is a lot of information out there about COVID and vaccines, and trying to kind of break through that clutter with a unified message is important. I would also say that I'm not sure if this is a learning, but it was it reinforced what we knew, that we need to have comprehensive efforts. And so I mentioned the outreach to our MAP members. That is really old-fashioned. The same with the business outreach, old-fashioned grassroots outreach, having a real person with a local phone number, pick up the phone and call people who may not have access to the internet, may not have access to media, and developing relationships to where they trusted the information, they trusted the caller, and that was, you know, nearly 5,000 connections where there was a conversation made. I think that was really important in our efforts. And then also just paying attention to the communities that we serve. So that the town hall series that we have worked on and developed with community care and our partners, I don't think that's new information that faith-based organizations play such a critical role. But the response, I think, has been really, really positive from the churches that we're working with and the members of those congregations as well. So those are some just high-level takeaways for me. And I would welcome, my team is on the line. If Yvonne or anyone else wants to join, I'd welcome their input.
Okay, Yvonne? No?
No, that was great. Thank you.
Okay. John?
Dr. Bell, if I could just take advantage of the prompt and weigh in from the healthcare delivery side and eligibility services. I think one thing we've learned from the pandemic is that virtual or telemedicine interactions with patients are not a one-to-one substitute for those face-to-face interactions and those phone calls that Ted mentioned. There are portions of our enrollee population that do not engage and do not interact at the same rates with the healthcare system or on an eligibility front if all we are offering is telephonic or virtual assistance. So I think that's something else that we have to keep in mind. You know, our Spanish-speaking enrollees in particular utilize our virtual application less, and that gives us something to work towards improving. I think we've also seen, you know, significantly lower utilization rates across the healthcare spectrum, which unfortunately points towards people not engaging in healthcare services, delaying necessary services, and not having the same level of control of chronic conditions and things of that nature. So just wanted to weigh in while we were talking about engagement from that perspective.
Excellent, excellent. Any other, Dr. Zamora, just wanted to welcome you. Thank you for joining us today. Interesting discussion. I'd like to open it up for questions from other board members. Manager Valadez?
Only after everybody else.
I'm not seeing any. Oh, now I see some hands. All right. I'll take Manager Jones first and then Manager Brinson.
First of all, thanks for the welcome back. It's good to be back. It's a whole different world, and we'll have time to talk about that another time. But I did want to acknowledge what I think Ted said and what Megan said from my opportunity to have served with the city, is that there was a great collaborative effort there in terms of working together in this community. And it's something to be applauded. And as a board member, I was very sensitive of that and very appreciative of that. Obviously, there was a learning experience for everyone, and hopefully it won't be another one, but it'll be 100 years from now, and we'll hopefully learn from that. But it'll also learning lessons from how do we work outside of just pandemics. So hopefully this will be an opportunity for us to talk about how we can collaborate better and synergize our efforts in terms of working with our community as a whole. So I just want to acknowledge that very much. Thanks very much.
Excellent, Manager Jones. Thank you for those remarks. And yes, it's the collaboration that happened around the pandemic is just really awesome. And it should lay the framework for us to continue to do that into the future. Manager Brinson?
Yes, I wanted to also say that it's an extraordinary effort. It was really well managed, organized, happened very quickly. But I'm curious if you know what kind of an impact has it had on people's lives? Have people changed their mind about getting vaccinated? Is there any way to tell how much more outreach is perhaps needed?
Mr. Giesland.
Yes, thank you for the question. And I see Manager Valdez applauding, and that's an excellent question, because it's one that literally I feel like is being answered with each passing week, maybe even each about every 3 to 4 days. The short answer is, you know, if you look at community care, their ability to vaccinate within communities of color is higher than perhaps what one might expect. But I think there's some nuances there to the data. But Dr. Brinson, there's still a lot more that needs to be done, and especially on the outreach piece. And I'll let Ted and his team speak to this, that there's great coordinated effort with APH, doing a significant media buy, as well as significant outreach as well outside of conventional media, as are a number of community groups. I know the Austin Latino Coalition, other faith-based groups. And I think what we're all looking at, and I'll finish the general response to your question with this, is when we look at those high impact zip codes, those 20 or so zip codes that we serve, and that are also, you know, whether you look at it by poverty levels or by social vulnerability index, the goal is to take those areas and improve the overall vaccine take-up rate. Not just look at the county on average and say, oh, we're at 60% now. We really want to focus on those vulnerable areas, because that's, to us, that's vaccine equity, or one way that we define vaccine equity. But we are literally pivoting on communications and outreach strategies as the days go by to be able to find, you know, what is most effective and what's going to work best.
Thank you, Mr. Geeson. Appreciate that. And any other questions from our board members? Manager Valadez. Manager Valadez.
Okay, I'm going to go starting backwards. But first and foremost, I want to thank Central Health and Community Care and Sendero for having, they are the heroes with respect to reaching out into hard to reach populations, especially non-English speakers. Now, what I'd like for us to do, Mike, if this is not already underway, is do a comprehensive analysis as to who we have reached and who do we still need to reach in different populations, respectful of our demographic population in Central Health. I think we need to know population by population, language, religion, whatever, what we have done and how better we need to overcome what we haven't done. Because I still believe that our first and foremost goal is to reach all the uninsured also. But I want to thank your team for having done all that work and to continue doing this work that is not being done by other entities. Okay, so that's based on what I'm hearing. I also would like to know if anybody would consider any payments to patients, especially as we are in this hesitancy, appear to be in a hesitancy environment. There are a lot of people that still believe that they're going to get chipped by some micro chip that's being placed in their arm. You know, there are people who are believing myths, but I think that with our much older population and with our millennials and younger population, maybe a $25 gift card or something, anything.
I think she froze. Doesn't look like she's coming back.
Dr. Bell, if I may,
go ahead.
I can answer questions, and this meeting is being recorded, obviously, and so we can memorialize her questions, and I'll start to respond as she logs back on, if that's acceptable to you, sir.
That is, sir. Please go ahead.
So on the incentive payment, yes, the internal team here has already begun to explore what we can do to provide incentives directly to the patients, working in conjunction with community care, but also the equity incentive payment program that we set up with all 3 FQHCs that serve Travis County. That provides a lot of opportunities there that, you know, through the uniqueness of the provider-patient relationship and the neighborhood relationships can certainly yield some other incentives maybe that we're not thinking about right now. So I think there's a couple of different approaches there that we're taking that will ultimately lead to that, what Manager Valdez had asked for. I also know that, you know, talking to Jason yesterday, that community care is actively planning on using some of their funding, as well as seeking other philanthropic sources to provide incentives for individuals to come in and receive the vaccine. And and I'm kind of taking some of her questions in reverse. I think with respect to mapping out, what it looks like in the underserved and disproportionately impacted communities, we are currently working with Austin Public Health to, and actually we're not the only ones. There are other entities that are also involved with this, community care, some of the ESDs and other leaders within the community. But it's a smaller subset of the larger vaccine coalition, or the vaccine provider meeting, I should say. I need to correct myself. It's the vaccine provider meeting. It's a smaller subset of that's working on understanding, okay, as best we can see 30, 60, maybe 90 days out, probably not further than that, who's going to be doing what, when, and where, and what's the communications and outreach strategy that wraps around that. APH to date, I think they're probably over 260, 280,000 vaccines. And so they're taking their mass mega and hub site, or mass and mega site strategy. And obviously they've been not only working on, but have converted to, and are can continue to convert to, more of a decentralized strategy. And so I think that's going to have a significant impact, along with what community care and the other providers in the community are doing.
Excellent, Mr. Giesland. Manager Valdez, you're back.
Yes, I've lost internet. I have no computer, so I'm using my telephone. I have no idea what kind of a picture you're seeing. And so what I'll do is let them continue to the next section, and then I'll just, if something I lost, I didn't hear what happened, but if something didn't get covered, you have my comments. Yes. And I just,
Manager Valdez, just so you know, these are being recorded. So he did answer 2 of your questions, and you can go back and listen to those questions. He answered them while you were logging back on. So you can get the answers to your questions that you put forth. And we'll just go on and move on from there. Before I move on, I know we've concentrated.
Wait, I just have one thing left to say, because I didn't get to say it, and it was going to be my last thing. If you don't mind.
Quickly, Manager.
Very quickly. Frank Fuentes with the National Hispanic Contractors Association was able to access vaccines from the governor and TDM. And so I wanted to know whether or not it would be reasonable for us to, at Central Health and Community Care, to be able to look at the marketing strategy, including incorporating the access to the vaccines that he has. He's got the vaccines, but he did not get any money for marketing or outreach. And so I'm saying that for Frank, and I'd like to know if that can be a consideration. And if so, Mike, would you please talk to him about that? Because that's a whole different bundle of vaccines that he now has access to, because the Latino population was being left behind so everywhere else. Thank you.
Thank you, Manager Valdez. Thank you. And I guess Mike will touch bases with you with regard to that.
Yes, thank you.
Like I said, we talked a lot about lessons learned, but before I go on and before we go on in the presentation, I do want to acknowledge Ted for all of that fantastic work that your team has done. I mean, it is amazing the activities that you and your team have performed with regard to outreach, media, videos, press releases. It really is. And just thank you, and thank your staff. I appreciate it.
Thank you.
Chair Greenberg.
I would like to add to that, Ted, thank you for all of the efforts that you have had to collaborate and coordinate on communications, outreach, and engagement with our partners and collaborators during COVID-19. And I do hope that this has set the stage with all this wonderful work that you've done in the collaborations that you have established for ongoing collaborations. Thank you and your staff.
Thank you, Chair Greenberg. All right, Monica, I'm going to turn it back over to you and we'll move on.
Thank you. And we're moving on to another big project. I'm going to hand it over to John Clark to talk about EPIC implementation, which is in fact epic.
You can say that again. Project was absolutely epic. Some of you that have been along for the duration know that 2.5 years ago, we began conversations about putting a new system in place that would help in our ability to provide better access to care, productivity for providers, and really help with the interoperability and some of the different things that are necessary to achieve the objectives that Central Health is putting forward. So the crucial thing that I will tell you is, just as a quick update, we did absolutely go live March 27th. A lot of people might look at that as a hey, we hit the finish line and we made it to the date, but I will tell you that date is actually the starting line. There's still years and years of work that goes into these systems after a go live. In fact, they never end. We have support and all kind of different things that go into that. So just some of the very highlights of this. There was probably about 11 months worth of constructed build that went into the development of the system and the implementation. We went through a large amount of data conversion from NextGen into Epic, including all of the critical information on patients going back 3 years and active patients. I also want to call out that we took the entirety of what was in NextGen for probably a 13 to 15 year time frame that they had been using NextGen, and we actually are in the process of storing those historical records into a data retention tool called LK, which will give the ability for folks to see a more historical view of their patients if they've been existing patients for that period of time. Let's see, again, the go live went on March 27th. We trained over 1,000 staff members in the process of doing this implementation. So all of it was a monumental, or as Monica pointed out, epic undertaking, and we are there. And it's exciting. It's exciting for me. It's exciting for the organization for a lot of different reasons. But I wanted to take just a brief second to give some huge accolades to the team that I have here in Joint Tech, the people that work so hard for you as a board, for this community, and for everybody here, and all of our patients and staff members to provide the tools and resources necessary to achieve not just this Epic implementation, but almost everything that you've heard of already today and everything that you will hear in the remaining of this meeting has some IT footprint to it. And it's just a monumental task to undertake this level of EMR and EPM transition during the same time that we were going through a COVID response, in addition to the changes that were going on due to the COVID response and other clinics that were being moved, and additional locations and growth of the organization. It's just an amazing undertaking. So I want to give a big shout out to the folks in IT and let you know that they're working very, very hard for this organization, and I appreciate them, and I know that you do too. So I also wanted to call out that anytime you go through one of these EMR transitions, they're not really necessarily only a technology solution. In fact, they're driven by clinical and operational workflows and operational efforts. And so I would be remiss if I didn't bring up the fact that community care as a whole really threw in everything that they could to making this a success. And without them, there wouldn't, Joint Tech would have got the system up and running, but it would not be as functional and as operationally sound as it is today. And so big shout out to Community Care and their partnership during the implementation. I also want to share with you that there are several things that this aligns with the objectives that Central Health has put forward. One of the big things that we've been striving for since I've been here, I know, and I think for quite some time prior to, is interoperability. With our change into the Epic platform, it gives us the ability to reach many more of those objectives with interoperability, the connectivity that we'll have with the national footprint and with other organizations here locally that are part of that national footprint is significant. Being able to see information when a patient goes to a health facility in Houston, let's say, or whenever they go, say somebody travels outside of the region, being able to get to that information. It also gives us better tools for accounting for all of that care as well, in the deliberate nature of the reporting tools within Epic that we did not have in NextGen, and were quite honestly having to be constructed outside of the NextGen system. So Epic gives a lot of ability from that perspective. In addition to that, provider satisfaction is another key thing that you want in a healthcare organization. When providers are not getting adequate when they're not having adequate work-life balance themselves, it makes it very difficult for them to come to the office every day and see the patients that we're serving. And it makes for a better experience for them and a better experience for the patient. The providers now have the ability to do documentation real time on the patient, and they're not spending their time outside of the office doing that documentation. There's still a ways to go with this, but it has improved greatly since our go live and will continue to improve. We've put exam room technology in each one of the exam rooms so that the providers will have direct access to the EMR while they're treating the patient. It's a phenomenal change for the organization. So I'll just say that so far, provider input has been tremendous, and I think that it's just going to continue to improve, and their efficiency is going to continue to improve. Patient interaction with providers. Many of you that are familiar with the vaccines that were being given out at CODA, and maybe some of the other clinics that Community Care was involved with, there was a tool that was being sent to patients that were getting those vaccines called MyChart. Subsequently, when we went live with Epic, we also turned on MyChart for every patient that is a patient of Community Care. They have the ability to go in and register under MyChart now and able to access all of their existing patient information through that. They're also able to use that tool to communicate effectively with their provider, and the provider to communicate effectively with them. So for those that have used that tool in other organizations, this is a phenomenal boost to the community that we serve, because beforehand we did not have that ability. The biggest thing that I really want to point out is the allowing better access to care. So as the continued use and the providers continue to get better acclimated and workflow optimizations continue, and people just become more and more familiar with the system, there is going to be an ability for the organization to start increasing the access to care in a way that we have just not been able to see with the NextGen platform. So efficiency, efficiency, efficiency. And we've got several things yet to do from an optimization standpoint. But as we continue with the system over the coming years, all we should see is improvement. So I want to give a big shout out to this board and to everyone for their insightful decision to move us along down this path. I just cannot even speak enough for the diligence and importance of that decision to this community when it comes to the care for the indigent population. So kudos to you guys for making that decision and making this a reality for Central Health and for community care and the patients. And that's it. I think I'm passing, I think either, Monica, I'll pass it back to you first.
Hey, thanks, John Clark. And Dr. Bell, we can either have Kit present on another kind of technical enhancement, which is the eligibility services, or open it up to Epic, whichever you prefer.
Let's Kit.
Okay.
Yes.
Good afternoon, Board of Managers. Thank you for allowing me this opportunity to provide an update, not only on the board priority of launching our customer service center, the call center, but also eligibility services as a whole. I too am very fortunate to be surrounded by an incredibly talented team. I'm extra fortunate in that many of our team members actually transitioned over from the city. And one of our management team members, Marta Hernandez, just celebrated her 31st anniversary working, and all of which except for 2 years of that have been working with the Medical Access Program. Becky Huerta is another longtime member who's worked over 20 years in the Medical Access Program. So we have a huge knowledge base and experiential base to ensure that we are continuing to improve our services. And this was really beneficial in launching our call center because we really drew on their expertise. And when Becky, who managed our relationship with United Way for the 10 years that we worked with them, was really able to provide some insight of what could we do differently to improve the services once we brought this in-house. And the thing that I am most proud about is the fact that executive leadership allowed us to hire not just customer service reps, which are typical for a call center, but actually to bring on and train our staff as eligibility and enrollment specialists. And this provides two functions for us. One, it greatly enhances our customer service to our callers because now our team, whereas in the past, if somebody was calling to check on the status of their application, United Way would make note of that and send us an electronic note to follow up with the client. If somebody wanted to start an application, they could start preliminary information, but then again, it would get sent over to our team. We now have staff that can go in and look at an account, and if all the information is there, they enroll that client right then and there. They provide the information and they mail a card to them. This is a huge difference in what we have been able to do in the past. It also allows us to ensure we are very productive and good stewards of the Central Health dollars. Because when there is downtime, Fridays are slower days for our call center. So rather than having staff sitting, waiting for calls to come in, they actually go in and pull applications that have been submitted online or via the mail, and they're processing those. So we are constantly working to get our clients through to enrollment. And it's a really exciting development. The staff that work on the back end predominantly or in person cover our phone calls during the lunch hour. So we never drop below 9 staff members on the call line during our high call volume time periods. So this has been a huge win for us. We're handling right now about 7,000 calls a month. We're receiving almost 10,000 calls a month. So we're continuing to work on that handled rate. It is improving each and every month, as is our hold time with the call center. You can see here on the slide that we are receiving about 1,000 applications a month that the call center staff have actually completed over the phone, have mailed to the clients to sign, add in their documents, and we've included a stamped envelope for them to mail them back to us. As John referenced earlier, this is a service that's predominantly used by our Spanish-speaking population who are less comfortable with our online model. And all of our staff members are bilingual English-Spanish speakers. And then we do have access to the language line in which we receive, because we receive a multitude of languages that are applying, and so that we can service our clients that way by accessing the language line. Our number one way to get applications right now during the pandemic is still through our online application, applyformap.net or inscríbase a map.net. We're receiving about 2,000 applications a month, and I have reviewed the data. We have literally received an application every hour of the day. I am amazed when I look in and see, yep, somebody applied at 3 a.m. in the morning. We receive about 100 applications each week that are submitted over the weekend. So again, this is an enhancement that of course was stood up very quickly because of the pandemic, but that is one that will not go away and that we need to continue to have 24/7 access to our population to apply for our services. But I am very excited to announce we have resumed our in-person appointment capabilities as of April 5th. We are seeing clients in our brand new Northeast Health Resource Center over off of Loyola Lane. Staff are really pleased to be in that site. And we are seeing each week more and more appointments scheduled at that location. We have always seen our individuals experiencing homelessness on a walk-in basis at Southeast Health and Wellness, and we have now opened up to our non-homeless population appointments at that location as well. One of the things I was remiss for adding to the slide, and thank you, Manager Valadez, for bringing it up, but it is the eligibility services team that does do the outreach for our CHAP and CHAP expansion members. Mm-hmm. Having the call center, again, internally, they made all of those outbound calls to our MAP members to get them enrolled in CHAP expansion. And we are currently working on an initiative for those that are eligible for enrollment during the special enrollment period. That is embedded into our work with our eligibility and enrollment specialists. They're educating folks, they're providing warm transfers in how to apply for marketplace insurance. And then we are doing proactive outbound calls to our MAP members that can transition. So this is work that we have taken on. We've done it now several years in a row. We're getting better and better at it. But again, having that call center functionality in-house, you all approving the ability to add this function to our bandwidth has just really made a difference to our clients, and we are looking forward to expanding the services that we can provide now that we have this capability. Thanks.
Thank you very much, Kit. That was an excellent presentation and very exciting. I also want to say, John, you guys have done an excellent job in implementing the EPIC project. And so I commend you for the work that you've done. And it is amazing what that particular system will allow us to do in the future. So thank you, John Clark. I appreciate that. And any other questions, comments by board members? Manager Jones.
Yeah, I just have a quick question for John. In terms of the EPIC system, I'm not as familiar with it, so forgive my question if it doesn't go to what it has capacity. But is there a way to utilize that data or to be able to ascertain mortality data of clients that were part of our system by connecting it or having referral information to Austin Public Health so that we have sort of a picture of that or not? And I'm not sure if the question came across clear, but let me know if you didn't understand that.
From the standpoint of working directly with the other partners, it's not necessarily capable of doing that, but every one of the partners that Central Health has is also a participant in the local regional HIE, and there's a lot of potential there for the gathering of information. And we are actually in the process right now of doing the integrations between the EPIC product that Community Care is using into that HIE, similar to what we had stood up for NextGen. So I think that maybe from the standpoint of gathering the data for mortality, there are a lot of very specific examples of how that data might be gathered, and that might take quite a long time to discuss. But in short, it's not necessarily a function of the EMR to do that. It would be a function of maybe some of these other larger data sources that include data from many organizations.
Maybe at another time you and I could talk about how we could do that, because I'm interested in what percentage or what contribution in terms of the mortality data that clients who are part of central health funding systems contribute to the overall mortality in the city and the county.
Yeah, I'm happy to have conversations with you anytime.
Thanks very much.
Great. Any other questions, comments by board members? I see you, Manager. Let me take Chair Greenberg first, and then I'll get to you, Manager Valadez.
Yeah. Well, mine's very quick. And again, thank you for the excellent presentations. They were both outstanding and so much hard work. And I would say from both of these that I see that there are things that we stood up very quickly during the COVID-19 pandemic that actually will be very helpful to us moving forward, and that we will, as I say, we'll keep the old friends, but we've made some new ones. We have some hybrid approaches that we can continue with. And I thank you both for all that you've done and for these presentations, and look forward to continuing these enhancements as we move forward.
Thank you, Chair Greenberg. Manager Valadez.
Okay, so since I'm in and out and not necessarily capturing what we have and have not covered, did we cover the FY 2021 strategic objectives and eligibility services? Those sheets have we gotten to yet?
Well, she covered the eligibility services, the strategic objectives for FY 2021. That's the slide that's on, but you can't see it. Yeah, so yes, that is it.
Okay, did we cover the strategic objectives that cover medical management expansion?
No, we've not gotten there yet.
Then I want to thank John, and I want to thank Kit for doing everything that they're doing for our population and for our still as of yet not enrolled in MAP or MAP Basic, because that's where I'd like to see the uninsured population go, at least into receiving some kind of access to services. So John, you know, as we have talked about IT&T in the past and have not, you know, it hasn't really come to fruition. I'm hoping this is the realization of that dream. And so as you used to talk about needing to put all the partners in the same room to get them to all agree to providing the same data in the format that's necessary to be able to analyze it and then spit it back out at Central Health or Community Care or Sendero or whomever else, so that we can focus on better targeting what it is we need to do for our populations that have especially chronic illnesses, et cetera, that lead to poor health outcomes, to try and improve those. Is that what this is going to be able to do?
John?
I think as a tool, it's not necessarily designed to do exactly what you just described. I think it's a big portion of the right direction for that. Some of the capabilities that we will have within the EMR enhance our ability to communicate with other systems that we did not have with NextGen, right? So sharing of information from one organization to the other is going to be quite different with Epic in a much improved way than what we had in the past. But when it comes to the actual repository of data, I think we still have quite a few challenges in the community with organizations' willingness to share. Now, I will tell you that, and again, I mean, a much broader conversation could be had about this, but there are a lot of rules changing when it comes to data sharing. Some of you may have heard of some of the data sharing rules that have made data blocking a thing of the past. So there are a lot of things happening when it comes to the ability for organizations to readily get to and access patient information. And so hopefully in the near future, we'll see some of those barriers start being lifted. Many of those things, I will tell you that there are a lot of those that are outside of Central Health's control. But I will tell you this: I am a huge a proponent and advocate for that on a regular basis.
So am I. So John, the sooner you can get us there, the better. If there's anything we need to do at the state or national levels to get rules changed, you know, I would have thought that for a public purpose or the public health issues, that we might not have had so many barriers to overcome, but apparently not. So keep getting us there, and I want to thank you for implementing that appropriately. And Kit, I want to thank you for your eligibility services. You know, I have a great respect for Becky, and I have met Martha, but I don't know her well, and I appreciate you talking about them and also about what you're doing for expanding MAP. But what are we doing for MAP in the uninsured world? Are we going out into areas and enroll and trying to reach out to them, or do we have contracts with people that do that kind of thing, so that the uninsured can ultimately be insured or access to some kinds of services? That's a big concern for me.
Yeah, Manager Valadez, this is where we really partner with the communications team, and it's really their work that goes and does that community engagement and education to help bring folks in. And we all work very closely together, but they are really our external face in trying to reach out to the uninsured population.
I appreciate that, and at least your eligibility staff is also enrolling, and they're doing it 24 hours a day. So accessing that information, whether it be online or not. And I do still appreciate you understanding that many of us live outside the digital divide, and you're trying to close those gaps. So thank you. Okay, thank you, Dr. Bell.
Thank you, Manager Valadez. I want to do a quick check on time. Monica, how many more parts do we have going forward?
So we have 3 more buckets of work to report out on for fiscal year 2021. We have specialty services, care management and the equity-focused systems of care planning work. Okay. And then we have the proposed fiscal year 2022 priorities, okay, and the proposed fiscal year 2022 operational priorities and the next steps. Okay.
So why don't we go through the next 3 buckets, no questions, all right? And then I'll open for questions, and then we'll go into the 2022 strategic priorities. Okay?
Thank you. Okay, so now I'm going to hand it off to Cynthia Gallegos to talk about the work we've done to expand specialty care access this year.
Thank you, Monica. My name is Cynthia Gallegos, and I am the director over the Service Delivery Operations Department here with Central Health. And I did want to say I thank you for the opportunity to share a few updates related to specialty care access. I wanted to make sure I recognized 2 key members from my team, Anissa Kendall and Megan Clark, who are on this call. They were instrumental in a lot of the updates that I'll be sharing today in the success of them. So I just wanted to put that out there. Thank you to you both. I will jump right into our IRIS camera expansion. Just to give a little bit of background on this initiative, IRIS cameras offer diabetic retinopathy screenings in the primary care medical home. The screening helps identify people with diabetes who are at higher risk of developing sight-threatening diabetic retinopathy, so that early treatment or intervention can be offered, and this is to reduce the incidence of vision impairment or blindness. So over this last year, we partnered with Community Care to expand this service by 9 additional cameras as of late April, on top of the existing 6 that we already had in place with that partner, making it available now at a total of 15 community care clinics. This is about a 72% overall increase for our patients, so we're really excited about that. This recent expansion has also provided the ability to offer more flexibility in IRIS screenings by offering mobile screenings for the patients. So that was a really big win this past year. Moving on to podiatry, we originally expected to launch surgical podiatry services in Q4 of this year over at Del Seton Medical Center, but we're really excited to share that we're anticipating an earlier start of June. We are continuing to collaborate with Community Care on the behavioral health support aspect for amputees as part of that work. The second podiatrist that we were working with Community Care to onboard actually started this past Monday. Just to share a little bit about that, one of the podiatrists that's currently on board is specializing in rear foot, and this new provider will be specializing in the forefoot, which really complements each other well. So that's super exciting. Surgeries for the second podiatrist are expected to begin in the last quarter of this fiscal year. And we are continuing work to expand to the ASC for surgical podiatry with an aim to go live this August. And just another little item to note, there was an opportunity for us for expansion for the casting as part of this program. So we're really excited to get that one off the ground for this population. Moving on to endocrinology, we have a second endocrinologist that will be starting at Community Care in August. This additional provider is actually going to help increase service access by 8 half days a week. Specifically focusing on diabetic patients who are in need of endocrinology services. And then as far as cardiology goes, we're continuing to work with our community care partners to expand these services in the next coming months. So we'll make sure to provide additional updates on that as the work progresses. And then last but not least, dialysis. Just wanted to share a little bit of history on this one in particular, in that services have worked to date by patients accessing it through the ED. And so that has actually been for compassionate dialysis and treatment of other chronic conditions. Separately, due to high utilization of the ER, some of the patients are given dialysis vascular access points. So those have been the two avenues in which patients have been receiving dialysis to date. As part of that work, we're going to be continuing to work through several agreements that we need to pull together in order to get outpatient services up and running. And we aim to do that by the end of this fiscal year. So I will stop there, Monica, to see if we want to move on to the next one.
And I think before handing it over to Veronica to talk about the medical management expansion, it's just to remind the board that when we're talking about these service access expansions, when we talk about the iris cameras, those are saving people's eyesight. Mm-hmm. So having access in the clinic so that people, when they go into the primary care clinic, can get their eyes checked in that clinic and learn if they've got too much pressure building up, that saves their eyesight, because sometimes they can't make it to a different appointment with an ophthalmologist just to have that screening. And when we're talking about a front foot versus a rear foot, having that level of specialty allows people to save their foot. They can do the smallest amount of amputation that's possible, or potentially do the limb salvage. And the same thing's going, making sure that we've got access to insulin pumps can keep people, keep their diabetes managed so that they don't go into chronic kidney disease and need dialysis. So all of these things, and then you guys heard the presentation on dialysis a couple of weeks ago, and the dramatic impact that has on the quality of people's lives and extending their lifespan. So thank you so much, Cynthia, and your whole team on this work that's having a huge impact on the patients that we serve. And so also speaking of huge impact, I'd like to hand it off to Veronica.
Hi, good afternoon. I'm Veronica Butron Camacho, and I'm the Director of Medical Management. So this fiscal year, we have done quite an expansion and doubled in our capacity and size in medical management. With that, we brought on virtually 11 new staff members, and we onboarded and trained them all as well. And that process actually ran really smooth. And I want to give big shout out and kudos to my entire team. None of this could have been possible without their feedback, input into developing new processes to make sure that the orientation process went as smooth as possible. We brought on 5 health management liaisons and community health workers. And with that, we also developed a community health worker orientation program that we launched as well, that really engages all of the enterprise-wide community health workers, and really developing that supportive environment to provide and equip our community health workers in the enterprise with tools to really manage this population. And that also does include community care health workers as well as syndetal community health workers. We have added on 2 additional social workers, 2 registered nurses, 1 resource eligibility social worker who has been instrumental in moving people over onto other sources of funding and helping patients get disability and transitioning them onto Medicare or Medicaid. We also have 1 manager of medical management as well. And with the addition of those team members, we have additional outreach capacity now. So we now have the on-site, we have on-site staff at 2 additional Ascension Seton facilities. That's Seton Northwest and Seton Medical Center, Austin. And we also have a community health worker who also is virtually for St. David's Hospitals. And what I will add to that is that with the addition of this supportive staff for those particular hospitals, they are able to identify patients currently in the inpatient setting or the emergency department who are either unfunded and would qualify for MAP. And we assist them, and we work very, very closely with our eligibility staff in trying to expedite some of those patients. We have discovered there are a lot of unfunded patients out there with chronic diseases such as congestive heart failure, end-stage renal disease, maybe new to Travis County. And it's really nice to have those health management liaisons and community health workers and staff in the hospital face-to-face with those patients to really develop that trust and educate them on-site, in person, and really be able to walk them through the eligibility process. I will say with the addition of having the online application process, that has been instrumental in helping us be successful in getting patients enrolled. Special populations team addresses patients with congestive heart failure and end-stage renal disease. As Cynthia mentioned before this presentation, you know, that dialysis program is going to be a life-saving treatment for many patients who need dialysis services. What we really try to do is collaborate and coordinate with community care, People's Community Clinic, and Lone Star to really identify those patients, to make sure we're getting a list of those patients, preparing them for what's to come, and really navigating them, but mainly connecting them back to their medical home and hopefully transitioning them at some point to funding sources such as the Blue Cross Blue Shield Fresenius program. So that is a true collaborative effort, and we want to make sure that we are helping our FQ partners in identifying those patients. Last but not least, we also have our post-acute skilled nursing facility transitions. Prior to this expansion of medical management staff, we had a couple of people in our case management teams that would transition people as they were staying in the skilled nursing facility and transition them to discharge. Now what we have done is we've been able to allocate a special team devoted to post-acute transitions. That really has helped with the efficiency of getting patients out of a skilled nursing facility, moving them into the appropriate setting. Many times that's home, but sometimes it's not home. Sometimes it may be to our residential rooming facility. And we have case managers and social workers that really work closely with those patients every step of the way to make sure they feel supported in that transition as well. And to close my presentation, I would actually like to read and share a letter that is a true testament to the work that we do at Central Health Medical Management and the impact that this work has on our community, the patients, and families we serve. This was a letter I received from a mother of a patient. Dear Ms. Butron Camacho, our son has been in the care of Ms. Huddleston, your social worker, who has been looking after him. He has been on the streets of Austin since last summer after years of repeated incarcerations and intermittent stays at home. Our son had intensive injuries to his hand and arm due to drug use with aftercare for his wounds and is at present at a Fresh Start home, which is our residential rooming. As a parent, I am sure I am not telling you anything new about the concerns, worries, fears, and anger, yes, anger, our family has been experiencing. On many occasions, not knowing where he was, how he was, I actually cut my hands and asked God to take over, literally handing him over to him. It is an enormous comfort to know that he has medical and emotional care, and yet there is guilt. Guilt for using benefits that I should be providing, benefits that may never bear fruit. Your office is doing the work for so many who are not able or willing to care for their own needs. I am so deeply indebted to your organization and certainly the people that make it work. Ms. Huddleston has spoken to him and is trying to guide him toward attending meetings and planning a life for himself. I hear her concern for him and find it humbling for her investment where I feel I have failed. Please let me extend my gratitude to you and your work and certainly to those who reach out each day. Thank you.
That is most touching. Thank you. Really appreciate the work that's been done here. It's just amazing, absolutely amazing. And the lives that you touch are just fantastic. Thank you, Veronica and Cynthia. Appreciate all of those great preventive activities that are going on there. Monica?
Thank you, Dr. Bell. And we have 4 slides on the equity-based systems planning, and Sarita Clark-Leach and John Morgan are also going to present on this one. And for the new board members who hadn't joined in January, and as a reminder, the reason that we're engaging in this equity-based systems planning work is because despite meaningful progress in the past few years to collaborate more to build out care pathways and a connected system of care, we're making progress, but we do not have a connected system of care today. Silos still exist in planning, silos still exist in data transparency, misalignment still exists in goals in different parts of the system, and it's not always clearly defined what roles and resources organizations across the system will take on. And this leads to fragmented care pathways and access shortages in primary, specialty, and behavioral health care, and disparities in prevalence of disease. And so as board members in fiscal year 2021, you prioritized this work to build a system of care that delivers measurable, timely access and high quality care for all, no matter what the background of the patient or who the payer or provider is. And as we've reported to you during this past year, we've taken a two-layered approach. The first layer is this phase 1 and phase 2 work, which is to identify benchmarks, high functioning systems of care and gaps in our current system, and then look to disparities, to areas of inequity, using our patient surveys and patient promise surveys that we do directly with patients, clinician input, and looking to our subject matter experts, many of whom you've heard from today, and begin to prioritize immediate work that we're going to be recommending to you today, priority projects for fiscal year 2022, many based on this data on the level of need and cross-cutting factors like the impact that the priorities will have and our ability to achieve them in the next fiscal year. And then we're also going through the process immediately to engage a consultant, which is this next level of work that's going to be the fiscal year 2022 work, to conduct a deeper needs assessment of service gaps, to help us take on in-depth community engagement, and that this will lead to the development of a longer-term strategic services delivery plan that we're going to be bringing back to you to recommend in December and January. And one of the things that we envision in this work has been, and that we've done in fiscal year 2021, is to identify disparities and inequities that are facing our patients. And also moving forward, we intend to look at those who should be our patients. Manager Valadez, this is something that you mentioned, and it is a key focus of this work. And as part of our goals, it's to recognize and address health inequities and reduce disparities, effectively use our clinical resources to improve outcomes, to improve quality of life, and ultimately to reduce morbidity and mortality in these populations that we serve today or that we should be serving. And this is big work. We aren't wrapping it up in fiscal year 2021. It will continue into fiscal year 2022, but we made significant progress to date, particularly in undertaking our current state assessment of our system and doing an initial identification of gaps and disparities so that we can identify short-term initiatives to undertake in 2022. And we also applied for and have been awarded a grant from the Episcopal Healthcare Foundation to support this essential work stream moving forward into the next year. And now I'm going to hand it off to Sarita so that she can discuss with you some of the initial disparity areas that we identified. And then John's going to discuss the key components of the system, identified gaps and priorities, and why these are some of the initial priorities that we've identified. Next slide, please.
Hello, everyone. The work we've done to date has identified disparities in disease prevalence rates among population subgroups for a number of chronic diseases. We've also found disparities among different outcome measures that speak to how well these diseases are managed. This slide and the next were selected because they illustrate those disparities for two chronic illnesses that impact the largest number of people in our population. They can also profoundly impact long-term health and quality of life. The gray vertical lines on these bar charts indicate the overall prevalence rate for hypertension in our population, which is at 24.42%. However, you'll know that Black enrollees have the highest burden of hypertension by race at 42.7%, followed by Asian enrollees at 32.6%. And when we reviewed measures that spoke to how well blood pressure was managed, we noted that by race, Black enrollees had the lowest rate of adequate blood pressure control at 58.2%. 37% of our members experiencing homelessness have hypertension, and those in care, only 54.2% have adequate BP management. And finally, Black patients experiencing homelessness have the highest hypertension prevalence at 47.1%. Next slide. Next, we'll focus on diabetes. Again, noting that the vertical lines represent the prevalence rates for the overall population at 14.34%. You'll note that the prevalence rate for our Asian population is at 19%, followed by our Black population at 17.3%, both well below the overall rate. Looking at ethnicity, you'll note that 15.4% of the Latino population have diabetes, and we noted that only 47.5% of Latinos have adequately managed glucose levels. Hypertension and diabetes, if not properly addressed, can lead to a host of other more serious conditions, including but not limited to heart disease, stroke, kidney disease, amputation, vision loss, etc. Multimodal approaches will have to be taken to close noted disparity gaps. These approaches may include targeted interventions, provider, staff, and patient education, including implicit bias training as it pertains to health equity, and value-based incentive payments relative to gap closures. We'll continue to look at our population and outcomes and experience through this equity lens so we can suss out disparities where they exist and address them. And of course, this work wouldn't be possible without the amazing analytics and reporting staff, particularly our epidemiologist, Jessie Patton-Levine, and our biostatistician / quality measures analyst, Sally Gustafson. Thank you.
Thank you, Sarita.
Dr. Bell, can you hear me okay?
I can, sir.
Great. I will jump in. I know we're running out of time here this afternoon. Good afternoon, managers. You all have seen this diagram a few times, and I'm sure you'll continue to see some version of it as we move forward into the next phases of our systems planning effort that Monica just walked you through. As a reminder, these are our internally identified components of a high-functioning system that we are working towards and trying to develop for our patients here locally. It's also how we've organized this exercise around systems planning as we are working through in-depth discussions on each of these components individually. If you recall, we also presented a subset of the component areas and a list of the initial 33 gap areas that surfaced as priorities in a prior meeting. In just a few minutes, I'll introduce our proposed FY22 service delivery priority areas that are immediately responsive to some of these early identified gap areas. But first, I'd like to identify a few of the emerging trends that have evolved in our planning process. The first is across each of these, we're really striving to build comprehensive systems of care. And that means moving away from standalone initiatives and projects and pilots that can inevitably be stood up as in a silo and as a result are ineffective because they're not properly connected to other major components that are necessary in the system. The second is part of what you just heard from Sarita. We are really aiming to take an equity-based approach in our systems planning work. It's very reasonable to ask what that means. And if it's not clear, I think it can mean a lot of different things depending on which area we're working on and what particular subject matter we're looking at. Specifically, I think it means that we are deliberately slowing down in our planning process to look more deeply in our data and understand the disparities, like Sarita just gave you a couple of examples of, within our patient population for different conditions and outcomes, but also reviewing national trends and understanding how different communities where subsets of our overall population are affected differently, even though they're diagnosed with the same condition, or in how they interact with the healthcare system overall. I think we're also trying to look at the underlying causes of those differences and respond to those. We're looking, as has been mentioned a few times today, at our data, how that data is captured, and if it's being captured at a level of detail that allows us to do those deep dives like you just saw from Sarita. We're also looking at the competencies and training around health equity and understanding disparities and bias that our local healthcare community undertakes in order to effectively understand and address these unique challenges. I think it also means that we're being more thoughtful in how we move forward with the services that we bring online and making sure that those services are placed appropriately, they're designed appropriately, they're implemented and communicated appropriately. We're conducting outreach and providing clinical education with our patients in a way that is appropriate for those communities that we're working with. I think it means that we're also getting more and more outside of the clinics, as you all heard from Ted's group, from Kit, from Veronica's team, helping our patients understand and navigate the complex system and not stopping at just bringing new services online. I'll try to highlight a few more examples that Sarita has provided me as we're going through some of these highlights today. Another theme that's emerged is there are a few chronic conditions that have surfaced and continue to resurface across our different planning areas and the components. Those include hypertension and diabetes that you just saw some initial information on. I would add cancer and obesity to that list, especially as obesity contributes to the complexity of the other underlying conditions. So you'll continue to hear more and more about hypertension interventions, diabetes interventions, cancer care, and obesity. I'd also highlight the development of services for our 11,000 annual enrollees who are experiencing homelessness is going to need to be a unique approach. And we've heard about this a lot. Simply our traditional healthcare system and our traditional methods of delivery do not adequately meet the needs of this more complex and vulnerable subset of our population. One of the things that we've seen is that our data really indicates that our population experiencing homelessness has worse health outcomes. They're less likely to receive behavioral health care services when indicated, and they're more likely to use the emergency room for care when compared to our patients who aren't experiencing homelessness. So it's going to require unique approaches to bring those services to our patients. Similarly, behavioral health and substance use, which I shouldn't combine, but I will for brevity today. Those two issues, behavioral health diagnoses and substance use disorders, continue to surface across multiple components of our system. Our population today has a prevalence rate for behavioral health diagnoses of more than 20%. Our research also indicates that we're not meeting the needs of this population. And due to Sarita's research, we know that we're especially not meeting that need for our enrollees who are homeless, for men in our population, and our Black enrollees. Alcohol use disorders in particular show up in large numbers in our patients' diagnoses, in our discussions with Veronica's team and our case managers, our providers, and unfortunately, in our healthcare utilization data. Particularly in a disproportionate way, the emergency room utilization and our hospital inpatient services. It's also important to note that this is one of the areas in substance use, specifically talking about alcohol use, that there are very few programs or treatment options available today for our patients. And finally, even though we've made some significant progress in the past couple of years, and we acknowledge we still have a lot of work to do, I think the most difficult part of this work from my perspective are the difficult discussions that go into prioritization and how we work on what we work on and when we work on it. I would share with the committee that there are a multitude of factors that go into how we prioritize and stage out our work. From a patient care perspective, we look at how a particular system gap might impact morbidity and mortality. We look for opportunities to move upstream, and for example, not just working on heart failure patients or those diabetics who are at risk for amputation, but also looking at new approaches to managing high blood pressure and blood sugar and providing dietitian resources so that we can prevent or delay deterioration in individuals' medical conditions. We also look at disparities in our data, such as those that Sarita showed you a couple of slides back. And we look to our subject matter experts, those here internally that you've heard from today, who have worked in these areas for years, also with our clinical partners in each of these areas, and to the consulting engagement that Monica alluded to a little earlier in areas where we know we have gaps, but we need some additional expertise to fully understand those gaps, identify pockets of unmet need, and define the size and scope of what we need to build towards. We also look at what we have the ability to move, and that's a particularly important one. That includes assessing our internal organizational bandwidth and expertise, our clinical partners' capacity and the timelines on which they can move initiatives, and where we think we can make meaningful progress. I'm going to move to the next slide, and if I can direct your attention to the right side of this slide, the last list of bullets, starting with specialty care or specialty care access, are our proposed FY22 service delivery focus areas. You heard today about all of the work that's been undertaken in the past year for the priority areas. And I think it's fair to say that when we focus as an organization on making some forward progress in certain areas, there's a lot of work and organization and alignment that happens to make progress towards that end. These are the service delivery focus areas that we are proposing the board adopts and directs us, staff, to move the needle in this area of our system. I'd like to spend a couple of minutes talking about this particular list, but we will come back in June and again in August to talk in more detail about each of these, but want to start socializing this a little bit now. You all are well aware that specialty care has been a priority for us for many years. Every year we identify a handful of service lines to prioritize and make improvements, and we have seen a significant amount of progress, but there's still a lot of work to be done. One thing I would emphasize throughout each of these bullets is I think we're fortunate that we're at the point now that we are really building on last year's progress and the year before that. We're not standing things up from the ground up as much as we have had to in the past. So when we're talking about specialty care access, for example, going into FY22, we're continuing to build on some of those building blocks that we placed in prior years. Next year in particular, we're going to continue our work focusing on chronic kidney disease and nephrology care. You all are aware that in the past years, we've worked to expand access to nephrology clinic services. We've transitioned patients to longer-term funding sources for ongoing dialysis treatment. And as Cynthia mentioned, we're getting closer to having a transitional dialysis pilot program that will hopefully launch by the end of the current year. Next year will be about ramping up and optimizing those services and building on the groundwork that was laid this year, and then helping our patients to navigate and transition as needed across that care spectrum. Similarly, we've had a number of initiatives around comprehensive care for our diabetic population. Community care alone has over 12,000 diabetics, and that's not including our pre-diabetics. In the past year, we've expanded access to endocrinology care and diabetic devices, as Cynthia mentioned, as well as our retinopathy screening services. We've also introduced the FQHC-based podiatry services and expanded access to wound care and casting. And this year, yet, we will still launch that surgical podiatry program specifically focused on diabetic limb salvage. And again, as that's coming online later this year, next year will be about ramping up that effort and then optimizing it, helping our patients navigate that very, very complex part of our system. We're also working with community care and continue to work with Ascension Seton to increase access to cardiology clinic services. And we're ramping up that effort to eliminate the current wait list that we have in that specialty. We're also working with community care to get HRSA approval to establish expanded neurology services in the FQHC environment. There are several other specialties that we intend to work in as well next year, but I think I'd like to bring it back to our equity focus and saying that part of this specialty care access work is looking at ensuring that our different subpopulations have access to a specialist and that we're not just putting a one-size-fits-all solution in place. We've noted disparities in our disease prevalence rates, such as with heart failure, renal failure, cancer, asthma, and COPD. And we will not move the needle on health outcomes for those subpopulations if we can't get those individuals in front of specialists in many occasions. I'll speak very briefly about healthcare for the homeless. It's clearly a large part of what we do, around 11,000 annual enrollees who are experiencing homelessness. In FY22, this likely looks like continuing to build out the continuum of care for medical respite services. It also looks like enhancing our mobile and street medicine capabilities, both in size and in their capabilities as a team. So that means more teams and a larger scope, specifically looking at including additional behavioral health care services, wound care services, and infectious disease. We're also beginning planning around enhanced eligibility and enrollment options for our homeless enrollees. We are thrilled to be back in the community doing face-to-face eligibility services, but our two current walk-in sites or face-to-face sites are not ideal for serving this portion of our population. Primary care behavioral health is simply lacking. We've got work to do there. We're really excited that this year Community Care brought on a director for behavioral health services, a psychiatrist named Dr. John Swanson. We're extremely happy to have him on board, and he's going to help lead this effort within community care to expand our behavioral health services that are available in the FQHC environment. Clinical and patient education and transitions of care are my last two. Clinical and patient education, this is specifically in the areas that align with our other clinical priorities. So going back to our patients with chronic kidney disease, with heart failure, those who are newly diagnosed with hypertension or diabetes, and creating the clinical education around those conditions. So I would encourage you to think of it both at a high level, so looking at it from a population health level of the large numbers of individuals who in our population suffer from diabetes and from hypertension, but also at a very, very discrete level of individual curriculum for very specialized solutions, like our relatively small population of heart failure patients. As Sarita mentioned, hypertension is one of our most prevalent chronic conditions in our population, and only about 66% of those with hypertension are adequately controlling their blood pressure. For our Black enrollees, that drops even lower, below 66, down to 58% control. As you all are aware, uncontrolled hypertension can lead to a number of other conditions and complexities, including renal failure, including heart failure, and some of those more downstream conditions that we need to treat. Diabetes is a very similar scenario. 14% of our population has a diabetes diagnosis compared to 9% in the overall Travis County population. So this is where we not only look at the disparities within our population, but look at the disparities of our population compared to our community, Travis County as a whole or Texas as a whole. We're going to continue building our supports for patients in transitions of care. This year, we've really focused on, as Veronica mentioned, transitions out of the hospital and to post-acute environments or to the complex primary care clinic. But there are critical transitions of care between every setting or every component in that diagram on the previous page. just as an example, one of the statistics that Sarita pulled for us was, less than 50% of our population has a follow-up visit with a primary care provider within 7 days of a hospital discharge. Now, that's one example of the kind of discrete measurable benchmark that we are looking at for us to be able to judge progress at a high level over the coming years as we continue building access and potentially more importantly, helping our patients navigate across the system. Thank y'all for bearing with me. I know I've provided a lot of information. Just as a reminder, we will be back to talk through each of these in more detail. There is a ton of work that's going on here. A lot of the folks that are on this call today have been participating in this effort, and just happy to be able to share it with you today.
And we have some more information still on this slide, which contains our overall proposed strategic priorities for fiscal year 22 and a couple more slides after this. So I think, Dr. Bell, if we have leeway, we may, go a little bit over. But what John just described is, I think our key focus are these immediate service delivery focus areas that have come out of our equity-based systems planning in fiscal year 2021. For fiscal year 2022, as John said, we are going to continue building on the work that we've done in 2021 in the systems planning area. Within the next month, we hope to have chosen a consultant that we can engage to assist in developing this foundational equity-based strategic healthcare service delivery plan. And these consultants, as part of building out this strategic service delivery plan between next month and December or January of the coming year, we're going to review the current and future population health needs for low-income residents of Travis County, both those we serve and those that we should be serving. And they're going to help us identify the needs that are being met today, to some degree, letting us know what percentage are we currently meeting, estimate what percentage others are meeting in the community today, estimate what is unmet today across the entire system and continuum, and also help us understand if we don't grow the services we're providing, what's going to be unmet in the future, and how much is that need going to grow over the coming years, so that we really can start planning out how do we reach out to the people that we should be serving, how do we get them into care, and how do we build out the capacity so that when we bring people into care, we have the capacity to serve them without large wait list, and we can improve their outcomes by providing that timely access to care. They'll also help us analyze the gaps and help us estimate the cost of increasing care to fill those gaps, and also fully develop the projects and initiatives that Sarita and John were talking about both today and in the future. And they're going to help us greatly expand our engagement of the community and partners in work groups, through community conversations, through roundtables, through surveys, through focus groups, through multiple modalities, all throughout the process, leading to board consideration in December and January of this Systems of Care Service Plan, and then following that in February through September of next year, we'll work on developing the operational implementation plan and long-term operational sustainability plan that will allow us to meet the gaps and needs that have been identified. As we're doing that work that leads into Objective 2, we will continue completing the work in Eastern Travis County with the site expansions, with the build out of the Hornsby Bend Health and Wellness Center in the Del Valley Health and Wellness Center, and the continued development of the Colony Park Center, and continue the work around building our sustainable financial model for healthcare delivery, which includes ensuring that there's a sustainable hospital service funding model that supports measurably timely access and high quality care, and that we ensure our long-term efficiency and land use that helps support our long-term financial sustainability, both through the continuing development of the Brackenridge downtown campus and through our use of the land assets that we have through the administrative consolidation. Next slide, please. Mike?
Yes, thank you, Monica, and members, for your patience. What you've seen so far is a number of initiatives, some continued that are building on our foundation and our pillars and the work that we've already done, some new that have a lot of outward facing attributes. It's how we serve people, it's where we serve people, but there are some things that we need to do that are internally. They may not be obvious to those that are on the outside, looking in, but to the board, they will be, to the staff, they will be, to our community partners that we engage with on a day-to-day basis, they will be. And it really points to organizational excellence and where are we headed with this. As we grow, both in size and in complexity, and as our operating environment changes from one year to the next, as you all have seen, our operational excellence, our basic blocking and tackling has to grow and excel along with our evolution and our maturity. So this fiscal year, we've talked about building a culture of equity and inclusion, and this is just one example of being an excellent organization. And you've heard from Jenna Allen and others on our Equity and Inclusion Task Force. You've heard from Lisa and Belina on the Hub Disparities study and the work that we're doing to improve upon our Hub contracting. And on our human resources recruitment and pathways and training, you've heard from Susan Willers and members of her team about what we're doing to become a more diverse, inclusive, and equitable culture. So this is one example. We've also, talked about in the last budget resolution for this fiscal year that you all adopted, it had a number of operational elements included in that document. We will need to start focusing more and more on what it is that we need to improve upon. So for example, an expanded compliance program. Again, as we grow in complexity, there's a number of compliance issues that will need to mature along with our processes and our policies to make sure that we're in compliance. We need to focus on change management and cross-organizational alignment. We are a lean organization, but we are one that must remain nimble given the changes that can occur, again, from one year to the next, sometimes more frequently than that. And we also have a number of subject matter experts that are throughout the organization in different departments that need to be aligned within working teams to make sure that, again, we're not working in silos, but that we're capitalizing on our strengths of collaboration and our skill sets. There are a number of operational strategies for certain critical areas that include, and these are just a few examples, facilities, technology, administration, et cetera. So the key takeaway in all of this is that in addition to the outward facing initiatives and work that we're undertaking, we need to start refining more and more operational objectives that also need to be achieved so that as we grow, we have the operational capacity that we need. And you'll see this mentioned with more definition and again, more refinement in the forthcoming budget resolution. This is where, and going back to the questions earlier on communications and outreach, making certain, for example, that in cross-organizational alignment, we have the communications and outreach capacity necessary that is a critical part to everything that we do. So with that, there's a number of staff, executives, subject matter experts, task force leaders that are on the call today that could answer some very basic questions, but I would ask the board's indulgence that as we get through this budget, as we go through the budget process, and we start talking about some of these operational organizational excellence priorities, that we have a fairly robust conversation around them as they come up, because we want the board and the public to have full awareness of what it is that we're doing internally to be a better organization. Thank you.
Thank you. We've just got, oh, sorry, Dr. Bell. One more quick slide, and also so people know that Brianna, really fast, we're going to be doing deeper dives in June 9th. We have a community conversation scheduled that Yvonne and his team are working towards, where we can present and gather feedback on these proposed priorities to community members on June 17th. And then we have another deeper dives in August. And then, of course, in September, we lead to the budget resolution being adopted. Thank you.
Thank you very much, Monica. Thanks, Mike. Appreciate all of this information. Managers, do you have questions or comments? Manager Valadez? You're muted, Manager Valadez.
Could we go to the screen that talks about the, I guess it's Sarita's 2 screens on hypertension and diabetes?
It's there.
Okay, one of the most important things for me is trying to compare apples to apples. And with respect to the percentages, one of the things I'd like to know if maybe I am quite misinformed as to what a percentage is or what the actual number is. I'm an actual numbers person. And so with respect to transitioning or transferring the actual numbers to a percentage, I would have to know the total of everybody in Travis County. If you want to do our population, I think it has to be the total in Travis County that have hypertension. Of that total number, you put in the number of Latinos that have hypertension. And you may want to break that out by gender, that Latinos or Blacks or Asians or any other population. From what I see here, the comparison is not doing that. This comparison is giving us a statistic based on, let's take for example, Latinos, okay? The Latino population that has hypertension is 14,751. And they're only being compared to what? The total number of Latinos in the county, or the Latinos in the city, or the Latinos in Central Health? I mean, I don't understand what that lower number is. I would expect that it would be the total number of population, period, that has hypertension, or just a total number of population, period. Okay. And then you compare the numbers based on the total numbers. In order to compare apples to apples, instead of, I'm comparing the total number of Latino population with hypertension to the total number of Latinos, to me that makes no sense. Okay? Now, I don't know who decided on that's what we're doing, but I'm curious as to whether that's what it means, because that's not what it means to me.
Okay, let staff answer that question. Sarah, I think it's Sarita that's gonna address that.
Sure. So Manager Valadez, what we're doing here is looking to understand what the burden of disease is relative to that specific population that we're looking at. So what you're proposing is looking at the overall proportion of that specific population, you know, of that rate in that way. But what we want to see here is how this specific population is burdened by that disease. So to do that, we're looking at the number of people within that population, how many of them are impacted by hypertension, by diabetes. And so that way, again, we get a sense of, is this disease particularly impacting this population in a way that it's not impacting another population? Because if you were to do this based on total numbers, what you would get is that the white population was impacted the most at all times because they just happen to be the greatest number within our population. So right. Statistically, it's going to be that, you know, they just happen to always will have the largest numbers just by the laws of statistics. Well, so first of all, again, wanting to look at that disparity, where does that burden disproportionately impact that population? Because if we were to understand that, if we want to really understand who's being impacted the most, we look at that burden relative to the entire population. So it's 14.34% for the whole population, right? And then within that, look at that burden within each of those subpopulations to understand it relative to that total population.
Where did you get 14 point something?
So again, that's our total number of enrolled population, our total number enrolled.
Oh, that's and then I'm sorry, excuse me. You may not have understood what I was asking. I didn't know what the lower number was. Is that lower number a number in the city of Austin? Is it in Travis?
No, this lower number is a total number. So if you're looking at Asian here, this lower number is the total number of Asian people within our MAP basic and the historical CCC sliding P population. Okay. The total number of those folks, and then within that population, how many of them are impacted by diabetes on the slide that we have up right now? How many of them are impacted by diabetes? And so again, you know, this gives insight, looking at those numbers, and we can look at them in a myriad of ways to get insight into, you know, the population. But this is the way we decided to look at it. And our epidemiologist is the one who looked at this metric, but this is the way we decided to look at it, because it really does give us the most insight into how this particular population is burdened by it. Because as you can see, you know, you have higher rates among some populations than you have others, even though the total number of that population might be smaller. And you have to ask why that is. Why is that happening?
I could tell you one reason. One of the reasons could be because one is a citizen and one is not. Because we did not take into account immigration status and or language. And so those things to me are overarching issues that we have to contend with in the health system realm. That is, a lot of people, not only me, believe that. Okay.
Absolutely, and we do plan to do.
And no, let me finish.
Sure.
And as a result of that, that is one of the reasons that I look to. Okay, let us see exactly how our population is being impacted. What you're telling me also is that we're not taking into consideration even Central Health's history. Central Health had a history of not wanting to enroll people in MAP prior to this, because whether they admit it or not, they were bound by an Ascension Seton contract that says we will only care for 25,000 MAP patients. And there was, whether you want to admit it or not, anybody who was around at that time, because I was not a part of the Central Health Board at that time, but I could talk to people who would say, well, they're not going to enroll me. They're not going to enroll me. They go to the MAP offices. They won't enroll me. I was in the MAP offices, sitting down, enrolling people in ACA, and listening to conversations as they went forward. And it wasn't until I was on the board that I understood that part of that was actually being controlled by the fact that Ascension Seton would not handle more than 25,000 people in MAP according to a contract that they had. Now, if I'm mistaken, then I'd like to know that Ascension Seton doesn't have that in place anymore. And if so, point to me in the contract or the modified contract where that exactly is.
Okay, Manager Valdez. Okay, thank you. Mike, do you want to weigh in a little bit on this? And
yes.
It would be helpful to actually try and get a basis for.
I totally understand, and we will attempt to do it. All right, Mike.
Yes, thank you. So, Sarita, thank you for answering Manager Valdez's question. Obviously, it's to echo what she said, Manager Valdez. It's the Central Health prevalence. You'll notice the title there on the x-axis of these graphs of 14.3%. But I think, you know, the issues that you bring up, really, it's not fair to burden Sarita with that, because these are, what you're bringing up are governance issues and affiliation agreement issues, some of which I think, and just kind of thinking about what you just said, are the subject of this mediation, which we brought updates back to the board in the appropriate setting and time for that. So ultimately those need to be directed towards me, but I hear what you're saying. And as you can tell from the data and what we've done, we're continuing to just grow and improve upon that enrollment, not only systems in place, but that experience for people. And that translates into better healthcare experience. And so I think we're all headed in the same direction when you think about board and staff and what you're saying, but I think some of those larger issues are probably reserved for mediation updates.
Oh, well, and I want to express my, please, Sarita, whatever Mike said, I did not mean for this to be a judgment or directed at you. The only reason I said your name to begin with is because you're the one that did the presentation.
That's fine.
And so I greatly appreciate you giving us that information, that background information. I'll have an offline conversation with you.
And I appreciate that, Manager Valadez. I think that's a great time. So, Sarita, and then I'm going to Manager Jones.
Sure, and I just wanted to mention one more thing. Like, it would be great for us to have data for all county for these populations, but unfortunately, you know, these data are based on diagnosis codes, and we won't have diagnosis codes for folks who aren't our patients or who aren't enrolled in our population to get to that level of detail. So that's another thing to consider. There are data limitations that force us to do this work the way we do it and to limit it to only our population. So when we can get wider population data, we use it. Otherwise, you know, we use what we have.
Then I would suggest that when we're being provided this data, if we can do like a preface at the top that says this information is only based on our population within Central Health or Community Care data only. That's it.
You can surely do that. That would be perfect. Yeah.
That would be, it would have eliminated my whole conversation.
That would have been nice. Manager Jones.
I appreciate that.
My suggestion is that we have, as a part of the budget process, at least one session in which we talk about population and demographics, because we vary in terms of our interpretation of that point of view. And secondly, I agree with what Sarita Clark Leach indicated, is that we only have data that we have. We don't know, and we can't speculate, or we shouldn't speculate about other things unless we have more supporting effort. So as we go into the process, I would encourage us, before we even get in there, because there is a big issue about demographics and the impact, what the epidemiology says about the demographics that we see. It'll be helpful if we're all on the same page, because I don't think we're currently all on the same page. So if we can have that as a preface for our budget, part of our budget discussion, I would encourage us to do so.
And thank you, Manager Jones. During your leave of absence, we did go through the demographic report, and we went through it fairly thoroughly. I think a summary of that and just a discussion of some of the differences in ways of interpreting that would be a good follow-up to be able to bring everybody on the same page. So I'll work with Monica and see how we can insert that into an upcoming meeting, or, you know, maybe work with Chair Greenberg if we need to have it at a board meeting.
Well, forgive me for not being aware of that. I'm glad that you had that conversation, but I think it would be very helpful to mitigate some of the type of discussion we will have a budget session around this whole issue. So
I totally agree with that. I mean, I think the review would be good for everybody. So
I'll work with you on that.
Thank you. Thank you very much.
We can also include that, Mr. Chair, if I may, in our community conversations that are coming up, both around the strategic planning, but as well as our budget-related community conversations.
Excellent, excellent. Okay. Any other comments before I close this? We are 15, 20 minutes over. So seeing none, I will go to item number, there we are. Agenda item number 3, confirm the next Strategic Planning Committee meeting date, time, and location. Managers, our next Central Health Strategic Planning Committee meeting is tentatively scheduled for Wednesday, June the 9th, 2021 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702, and or remotely by video conference, depending on the status of the governor's disaster declaration and stay-at-home orders. At this time, I'm ready to accept a motion for adjournment. Okay, I'm sorry, I went away from my screen for a bit. I've got Chair Greenberg with a motion to adjourn. I have a second by Manager Valadez. All in favor?
Aye.
Any opposed? Any abstaining? We are adjourned. Thank you, staff. Thank you, board
members.
Thank you,
members.
Thank you very much.